Welcome, Dr. Mona.
We are
Good
live.
evening, delegates. Good evening, delegates, faculties, members, and our participants. Thank you for joining Shield Connect, and we are back with our hit series Icons in Conversation with Dr. Ritu. So let me introduce our moderator, Dr. Ritu, ma'am, who organized this program every week. So Dr. Ritu, ma'am, is obstetrician and gynecologist, IVF specialist. Ma'am is founder and CEO of 360 Degrees Healthcare Studio. Ma'am is consultant at Inamdar Multi-Speciality Hospital in Pune. Ma'am is infertility test tube baby specialist done NUHS Singapore. Co-founder of MAAM, board member of SGS
Your voice is breaking, Nishant.
first icon for this series. And today's is it audible now?
Yes, now audible. Yeah.
So now let me introduce Dr. Kanchan Sharma, ma'am, who will take the topic challenges of obesity and infertility. So before we start with the session, let me give a brief introduction of Dr. Kanchan Sharma, ma'am. So, ma'am is the director and chief consultant of Akash IVF Center in Kanpur. Ma'am is secretary of Kanpur Obstetric and Gynecology Society 2021 to 2023. Ma'am has 33 years of experience. Ma'am is president of IHRF in Kanpur, ERT specialist, laparoscopist, colposcopist. Ma'am has done training in ART and embryo handling training from Netherlands and Rainbow IVF Center from Agra, operative laparoscopic training from Mumbai and France, ultrasound and fetal medicine from AIMS, Delhi. Ma'am has been awarded with Foxy Achiever Award, Pratignya Social Impact Award, Empowered Women Award, Nari Ratna Samman and Corona Warrior Award, Nari Suraksha and Nari Samman Award from Police Commissionerate of Kanpur, Lifetime Achievement Award from Cox Kanpur. And ma'am is organizer of many national and international conferences, organizer and chairperson at Ultrasound Workshop of UPCOG in 2015, quiz master in WWCon conference in which respected President of India was present. Ma'am is also speaker in the National Conference of Hyderabad and MOX 22 in Aurangabad, faculty in Femtech 1, Mumbai. And ma'am has a post of Vice President Honorary Joint Secretary, Cultural Secretary, Library Secretary at IMA in Kanpur. So I welcome Dr. Kanchan Sharma ma'am for today's webinar. Thank you, ma'am.
Thank you for nice introduction. First of all,
Yeah.
I want to congratulate and give my sincere thanks to dear Dr. Ritu Santwani, who is icon. Really, she is very brilliant and doing a very good work. Lot many congratulations and blessings to you,
Congratulations, ma'am.
Ritu.
Thank you, Kanchanji. Kanchanji, but today you are the icon of the day. Let me welcome you first. Let me first welcome you. Huh? Yeah. So let me first welcome you. Then I am handing over the dais to you, ma'am. Huh? So hello, friends. A very good evening to all of you. A warm welcome. I welcome all of my friends who have joined all across the geography. Some friends have joined via the Zoom link, but mostly joined via YouTube. So warm welcome to all of you. So friends, as we all know, that obesity is the very burning problem, and our India is at present is the obesity capital of the world. So today, to discuss with this important topic, obesity and infertility, none other than my very dear senior Dr. Kanchanji is here. So Kanchanji, a very warm welcome to you. I know your schedule is very hectic these days. You are too much busy in organizing the conferences, but I can say one word. Kanchan ji is the iconic who is the beauty with brain. मैं जब भी कंचन जी को मिलती हूँ, sorry English, because most of the friends went across the geography. So whenever I meet Kanchan ji, I always tell Kanchan ji, what's the secret of your this anti-aging? And you are so graceful. And thank you, Kanchan ji. I know you have accepted the invitation in a very short notice. So thank you once again from the bottom of my heart. And we all are eagerly waiting to hear you. Over to you, Kanchan ji.
Thank you, dear Ritu. You are always very loving and near to my heart. Thanks for the nice word. permit me to share the screen.
Yes, sure, Kanchanji. So friends, before Kanchanji is starting, whatever the questions, please keep ready your questions. As soon as the session will be finished, we will first take the questions for this session. Yeah, over to you, Kanchanji. Yeah.
I think my slides are visible.
Yes, ma'am.
And, and I am clearly audible, na?
Yes, loud and clear. Yes, perfect.
Okay. Thank you. Because now the era is coming of non-communicable diseases. Metabolic diseases, these are being very important. Our national Foxy president and all over India, we have a movement against the obesity. Obesity is one of the part of non-communicable diseases. And while treating the infertility, we infertility specialists have to think about the obesity, because there are a lot many challenges of obesity and infertility. If I talk about the obesity, obesity is a condition where there are many things. Like if we talk of the mother, maternal obesity have more than 30 kg per meter square has a significant detrimental impact on the fetal development with an increased risk of the fetal anomalies. If we talk of the PCOS, usually many PCOS patients leaving apart the lean and thin PCOS, most of them are the obese. They are having, they are having hypothyroidism and ovulation problem. In these obese ladies, it is seen that there is malfunctioning of the hypothalamus or the pituitary gland and leading to the production of the immature eggs. This obesity operating through a functional state such as the insulin resistance can create hostile intra-ovarian or the intrauterine environment for the oocyte or embryo. These obese patients, as we see, because the hormonal disturbances have oligomenorrhea, they have the chronic anovulation, lower pregnancy rate, higher miscarriage rate, increased obstetric complication. So obese women, even they don't respond to fertility medication and have higher percentage of immature eggs. So it's very difficult to treat even these obese patients till they reduce their weight. There are lower number of collected oocyte in these obese women. If we see that in these obese women, there is a percentage of free testosterone elevated due to obesity-related decrease in circulating level of SHBG. This is very important point, and I have to repeat this important point many times in this presentation. If we talk about the obese PCOS women, they have more marked hyperinsulinemia. There is insulin resistance. Each and every point is very important. There is a relative hyperglycemia in these patients, lower level of SHBG, higher level of total and the free testosterone and DHEAS in these patients. There's a decreased GH pulse amplitude and increased LH pulse frequency. There's attenuated LH pulse amplitude. So all of these led to anovulation and infertility. This is very important slide because it shows that juvenile obesity is very important. Age old time, the time has gone when the ladies do say कि बच्चों को खूब खिलाइए, खूब मीठा दीजिए, they should be chubby, mota mota. But now we understand by the science that this juvenile obesity is again very harmful. You have to restrict and give the proper nutritious diet, low calorie diet even to these young growing children, because the juvenile obesity is associated with earlier age at menarche, peripubertal, and the prepubertal onset of obesity is associated with higher risk of the oligo-ovulation and the menstrual irregularities. So there are more chances of menstrual irregularities in these juvenile obese persons. Hyperinsulinemia with childhood obesity plays a role in hyperandrogenism and the peripubertal ovulatory dysfunctions. androgen status tracks from the childhood to adulthood is directly related to fertility. So definitely we should have a control over juvenile obesity. Coming on the adolescent obesity and the lifetime nulliparity. It is seen that as the adolescent obesity percentage increases, there are more and more chances of lifetime nullipara or infertility. So obesity and pubertal ovulatory dysfunctions, if we discuss about this, the same, the aberration in androgen production that happens during the puberty due to obesity or the related metabolic complications may have long-lasting effect on the reproductive function. So this is very important. These hormonal changes have long-lasting effect on the reproductive functions. Because of elevated BMI at the age of 18, that is a risk for subsequent ovulatory infertility with or without a diagnosis of PCOS. This is very important article written in American Journal of Obesity of Obstetrics and Gynecology. So if we talk that fat tissue is also the site of steroid metabolism. In all these, androgens are irreversibly aromatized to estrogen, resulting in overproduction of estrogen and the functional hyperestrogenism. So in these fatty patients, there is usually hyperestrogenism. How does this estrogen level come to the excess? There is excess body fat that led to alteration in estrogen metabolism, which in turn may affect the HPO axis and led to ovulatory dysfunction. Eumenoric obese women demonstrate the lower circulating SHBG level. And there is a free fraction of circulating E2, which is again, as seen, is higher in the obesity. And the catabolism of the estrogen may also be altered in obesity. So catabolism also become less. And there is higher E3 catechol estrogen ratio, which further contribute to functional hyperestrogenism in these obese persons. Excess estrogen may affect hypothalamic pituitary axis. What does this excess estrogen does? It affects hypothalamic and the pituitary axis and led to ovulation dysfunction, ovulatory dysfunction, menstrual irregularity, and increased risk of the breast and the endometrial cancer. So we have to be conscious about all these things. This obesity lowers the plasma concentration of SHBG secondary to elevated insulin. Alteration in SHBG level have a profound impact on metabolism and action of the bound steroid, as I have already discussed. This excessive leptin is there. This is very important point in these obese persons. There is excessive leptin, which may impair the reproductive function at the level of ovary. Abdominal obesity is associated with both insulin resistance, elevated androgen, and it again causes hyperinsulinemia and insulin resistance, which in turn led to ovulatory and the menstrual disturbances. Adipokines. What are the adipokines in the obesity? We all should know that in obese persons, there are few adipokines which are very important. These are adiponectin, resistin, and the leptin. The level of adiponectin that is decreased, while resistin and leptin is increased. What does these cause? These cause a harmful effect. They cause increased this adiponectin, which is decreased, that usually causes increase in fat oxidation and increase in insulin sensitivity. So when this is decreased in fatty patient, there is reduced fat oxidation and more storage of the fat and reduction in insulin sensitivity, that is insulin resistance, that increases. So this is very important effect of all this. The presence of obesity is associated with number of disturbances in androgen, estrogen, binding globulin, insulin, glucose, gonadotropin, prolactin, and the growth hormone. So all these factors are very important for the fertility. The hormone leptin produced in and secreted by the adipose tissue affects the neuroendocrine reproductive axis both centrally and peripherally. So some or all of these alterations may play a role in the genesis of obesity-related ovulatory dysfunction. Coming on the prevalence of the obesity, this is very important. If we talk of the UK, 18.3% of the female population in the reproductive age suffer from the obesity. In USA, overweight are 64.5%, while obese are 30.5% and extremely obese are 4.7%. While with the open eye, we can see that in India, the urban prevalence of the obesity has increased alarmingly. So we are discussing about this topic. Almost 50% of adult urban Indian and 29% of the children even, they fulfill the criteria for either overweight or the obesity. If we talk of the definition of the obesity, according to current guideline for overweight and the obesity, BMI is equal to weight in kg upon the height in meter square. So WHO and CDC definition for adults is BMI of 25 or more is overweight, while 30 or more is obese. I have shown the full classification. BMI 25 to 29.9 is overweight, while 30 to 34.9 is obesity class 1. 35 to 39.9 is obesity class 2, while 40 or more is obesity class 3 or extremely obese. So risk of infertility has been shown to be threefold higher in obese than the non-obese person. In particular, 2 studies performed in the large cohort of Danish women planning pregnancies, it showed an inverse relation of fecundity with respect to the BMI increase. Other study was also very important by the G. Singh and co-worker that shows that more than 7,000 women proved that probability of spontaneous conception linearly declined with each BMI point more than 29 kg per square meter. This is very good diagram which shows that in the male, not even in the female, but even in the male, this obesity is a very important causative factor of the male infertility. Is lower among men with BMI of 26 or more and further decreases as BMI rises. So for every 3-point increase in BMI, the risk of infertility rises by 12%. Every excess 10 kg might reduce a man's fertility by 10%. So very important point that indicate that you should always try your patient that they should be counseled to lose weight. Obesity is associated with altered spermatogenesis and the erectile dysfunction. And it again reduces the fecundity. There is a direct correlation between BMI and the semen volume and the sperm quality. Very important points. So obese male express a characteristic hormonal profile described as hyperestrogenic, hypogonadotropic hypogonadism. Both total and the free blood testosterone level decrease in the obese men. So primarily this is attributed to an increase in circulating estrogen from the peripheral aromatization of 17-9C19 androgen that result in relative hypogonadotropism.
Sorry to interrupt you, Kanchanji. Sahiti, please mute everyone. It's creating a lot of disturbance in between. Please mute everyone. Yeah, Kanchanji, please continue. Yeah.
If we talk about the male person, obesity and infertility, this is a very good representation that how obesity affects the males and causes infertility. It causes infertility in males because of the physical disorder, causing erectile dysfunction, may affect the genetic disorder, may causes hormonal disorder, thus in turn causes erectile dysfunction and cause altered seminal parameters and result in infertility. So in short, we can say what are the factors in male obesity? Male obesity alters the sperm function. It increases the sperm DNA damage, decreases sperm mitochondrial activity, induces seminal oxidative stress, impairs the blastocyst development, reduces pregnancy outcome in ART, and increases miscarriage in ART. While talking in the female, again, a very good diagrammatic representation, I can say, because if we go towards the uterus, it is seen that in these obese ladies, there is reduction in receptivity of the endometrium. There is atresia of the early follicle and apoptosis of the follicle. And TNF, alpha, FFA, IL-6, leptin, and estrogen, androgens, they all increases, which again reduce the endometrial receptivity. There is insulin resistance and hyperinsulinemia and reduction in SHBG. There is reduction in GnRH from the hypothalamus and gonadotropin from the pituitary gland. These all factor in combination causes infertility in these obese persons. So, treatment of infertility and the reduced responses in obese patients are the major challenges of infertility. It is seen that when these ladies, obese persons, they come to us for the infertility treatment, the response to clomiphene is also less, as seen in many studies. Association between obesity and the total amount of the administered FSH, if we see that more when as the obesity increases, this chart very well shows there are more amount of administered FSH is needed to get the same response. Impaired responsiveness to gonadotropin is also there in these obese persons. There is increased duration of stimulation, increased amount of gonadotropin which is needed, increased cancellation of the cycle rate is there, a lower number of the medium or the large follicles are there, decreased number of the oocyte retrieved is there. And the very good diagram which shows that the female body weight and the number of the oocyte. This shows as BMI increases, there are reduction in the number of the oocyte obtained. And again, the female body weight and the number of the embryo. As the body weight or BMI increases, number of embryo obtained, again they are reduced. Live birth rate is also reduced as the age of the patient increases and the weight is also, BMI also increases, the live birth rate decrease. The predictors of the live birth is very well shown in this representation. It shows that as the BMI and the age increases, the live birth predictors again reduce. These are some studies which I am presenting. Risk of ovulatory disorders. This table shows that as the BMI increases, there are more risk of ovulatory disorder. Endometrial gene expression in the window of implantation. So it is seen that obese versus control obese with the PCOS, that there are more chances of dysregulation in obese persons, that is dysregulated transcription and the biosynthesis. There is a defect in all these. Obesity in surrogate, even in the surrogates, if they are obese, there is impact on the outcome of our IVF processes. So how to manage this obesity, which is such a dangerous, you can say. Obesity has a profound impact on the infertility management even. Women should be encouraged to lose the weight prior to infertility treatment. As we see in our OPDs that we used to counsel our patient, do they understand? This is our duty, that we should counsel them well, and they should hear us and try to lose their weight. Weight loss as small as even 5% causes decrease in free testosterone level and increase in SHBG levels. A 7 to 10% reduction in the body weight is effective in restoring fertility, resulting in spontaneous ovulation or increased sensitivity to ovulation-inducing drugs. So how to reduce the weight? By the lifestyle modification, by the medical treatment and the bariatric surgery. Behavioral strategies are very important. Stress monitoring is very important. Dietary intake, reducing the calorie intake by 500 to 1000 kilocalorie per day. Physical activity, moderate activity, brisk walking, jogging, even 30 to 45 minutes, 4 to 5 days a week. Adjunctive pharmacotherapy, drug treatment for the patient with BMI more than 27 can be advised. Surgery in rare cases where there is more than 40 BMI or a patient is not losing weight with any other way. A very funny diagram: lose weight and get pregnant. The weight reduction plays major role to make the patient fertile. This is my real-time experience. Mrs. Meena, who was aged 29 years with BMI 40 and her husband's BMI was 38. She was married for last 6 years and infertile. Husband is overweight and had erectile dysfunctions. Female, a case of hypothyroid with the hyperprolactinemia. Her both the tubes were opened. Couple was counseled to reduce the weight. Initially, they could reduce only 3 kg. They had a poor response in IUI 3 cycles and 1 cycle of IVF. They were recounseled and were given strict instruction to reduce the weight. This time, they managed to reduce 10 kg weight, followed by a successful IVF cycle and a beautiful baby with them. So in conclusion, overweight and obesity, obese women need longer time to conceive and undoubtedly are at the higher risk of infertility. Higher BMI is also associated with adverse pregnancy outcomes such as gestational diabetes and hypertension, and women undergoing in vitro fertilization may experience negative outcome at the higher rate than the normal weight female. Obesity is one of the major non-communicable disease which needs greater attention in today's scenario. So to bear the children is one of the major challenges for obese couple. Thank you so much. Thank you, Ritu, and all the audience.
Thank you, Kanchanji. Such a brilliant presentation and awesome slides you have made. Really very impressive slides. So friends, if any question, because I think such a lucid presentation and self-explanatory, all the things Kanchanji has covered very nicely. Only there was one question by Dr. Kiran in between. Kanchanji, you can see in the chat box. There is one question from Dr. Kiran Oswal. Dr. Kiran Oswal is a dear friend. He joined from this Karnataka, a very big name of the Karnataka.
Dr. Kiran Oswal.
Yeah, hi, Dr. Kiran. How are you?
Very, very fine. Nice to see you.
Hello, hello.
Yeah, same here, same here.
Namaskar, Dr. Kiran. Yeah,
Good
what is
you
the
have
question?
joined.
You can
Dr.
stop
Kiran.
yourself. Lipoedema or
Lipoedema.
xanthema is treat same as PCOD.
Patient with obesity and PCOD, patient with lymphedema and PCOD.
Obesity and PCOD and
or
lipoedema and PCOD.
PCOD. Treatment remains
Actually,
same or different?
Because of certain changes because the fat is more in both, because of the certain changes in hormones, as I have told that all the adiponectin changes are there. So usually these patients, there is a obese PCOS is a entity. So that is more in both of them. Usually because in lipoedema, can you tell me the difference between lipoedema and the obesity? First, I am asking to you.
So subcutaneous fat is more in the buttocks. That is a pear type and apple type of obesity what you get. Here in the lymphedema, what are the fat cells accumulated around the hips will get edematous. But in obesity, the fat cells will be accumulated more in number. So the treatment totally lymphedema doesn't have any effect like metformin, whatever you use, dianosine, DCI, myoinositol have got very less effect in lymphedema with the PCOD. That is lipoedema, not lymphedema. And
that's why the same thing.
Lipoedema is a different thing.
Different thing,
that is other than obesity. Here we are
Number of
discussing
fat
as such
cells
obesity.
are not so more. Number of the fat cells not so number increased, but each fat cell has got edematous.
That is a
So
genetic problem, more of the genetic problem rather than a metabolic problem. This is a
Nowadays,
metabolic.
definitely, it is very important to differentiate between the obesity and lipoedema.
Lipoedema, yes, right. Because of the different in the places of the collection of the fat and the type of the fat cells usually. Thank you so much.
Here I want to share one thing. What happens now these days, so many patients are coming in the OPD and saying, जब हम उनको बोलते हैं ना weight loss के लिए, तो they give the simple answer, मैम ये तो हमारे genetics में है, so हमारी family में सभी कोई मोटा है, इसके लिए हम भी मोटे हैं. Means very simple answer. तो I only give them the only one answer, क्योंकि आपकी family में कोई भी run नहीं करता है, इसके लिए सभी fat है. अगर आप आज से भागना शुरू कर दोगे तो सबका automatically control में आ जाएगा. जब मैं कर सकती हूँ तो कोई और क्यों नहीं कर सकता.
And Ritu, the type of the diet हमने देखा है ऐसी families में ये लोग खूब sandwich butter खूब सारा लगा के खाते हैं. They are all are taking rice and potatoes खूब सारा. The type of the diet is different in their families. They have
diet and exercise nobody wants to do. Always they want shortcuts. One is early morning, get up and warm water with honey plus nimbu. बहुत कम हो जाता है वजन, impossible. Then they go for Sona belt to the abdomen. Then they go for herbal treatment, not of side effects on the liver. Then they will come to us with 98 kg, 95 kg.
Right.
Then they बोलेंगे डॉक्टर साहब आपको गारंटी दे दो ट्रीटमेंट का. क्या गारंटी देंगे यार?
And they give the examples कि मेरे भला का भी इतना वेट था, उनके तो 2 बच्चे हो गए, तो मेरे भी.
Very true. Chalo, thank you, Dr. Kiran, for joining, and thank you, Kanchan ma'am. So now we are having none other than we all are waiting for our very most respected Ajay Mane sir. Sir, warm welcome. Yeah, Nishan.
Thank you, Ritu.
Yes, ma'am.
Sir, one minute. First, we will do the official introduction. Yeah, Nishan, please go ahead. Then I will welcome sir. Your voice is breaking, Nishan. Acha, leave. I will only read. Sir, a very warm welcome. As we all know, sir is Vice President-elect for Foxy. Sir is member NIMC, medical legal consultant since 18 years for free of cost. Here I want to highlight that sir is always ready to help whosoever calls sir. Sir, बहुत सारे conferences में भी जब होते हैं तो sir सबको बोलते हैं कभी भी कुछ problem है, so you can call me at any time.
Yes.
Sir is chairperson. Nishan, I am reading you it. Sir is chairperson, official MOX website 2018-20, 2022. Chairperson for Sexual Medicine Committee, Foxy. Chairperson for Adolescent Health Education Committee, MOX. Past President for Aurangabad Obstetric Society. Ex-Superintendent for MGM Medical College, Aurangabad. Trainer for Foxy Adolescent Health Committee. Health Advisor for Sports Authority of India. Charter President Rotary Club of Aurangabad, Elite. I think these all things are very less. Only one thing I can say, the man with a golden heart who is always ready to help everyone. Sir, a very, very warm welcome to you. Sir, we all are eagerly waiting to hear you. First, you finish your talk, then there will be a bombardment of questions.
Yeah, thank you, Ritu ma'am. And
ma'am,
thank you.
मैं खाली Ritu sir. Ritu ma'am.
Okay. ठीक है. Okay. Thank you, Nishant bhai, for the education support. And thank you, Kanchan ma'am, for adjusting timetable for me. Just now I joined. So
thank you so much. Meeting you, seeing you after a long time, and you are always a good orator.
Thank you, ma'am. Thank you very much. Okay. Is it a full screen now?
Yes, sir. Yeah.
Yes. Thank you. Thank you very much. Medical legal issues in obstetric practice. As suggested this topic by Ritu ma'am. Thank you, Ritu ma'am and team, Dr. Kanchan, all delegates, and Nishant bhai, of course, who is always in support for the academic purposes. Okay, let us discuss some situations. Fine, my voice is okay.
Yes, yes, clear.
Yes, yes, thank you, ma'am. Patient came with a pregnancy of 17 weeks for first time, and her age is 17 years. What next? So her pregnancy is 17 weeks. It is of no issue for us, but her age is 17 years. So less than 18 years completed comes under the POXO. POXO, what is POXO? It is a protection of child from sexual offenses, is the long form. POXO came in existence and in appliances in 2012. Since 2012, we are applying POXO Act, but nobody knew in 2018 they have some amendments and it has become more strict and stringent. So we need to inform the police or child welfare committee before doing anything. If a girl comes to you with a pregnancy and she is less than completed 18 years. So what is the condition? Completed 18 years is the definition of adult in India. If she is less than 18 years, married or unmarried doesn't make any difference. If she is married, inform. If she is not married, inform. Fine. 17 weeks is no problem. Okay. There is one situation that she is 18 years completed before 1 month and again 17 weeks pregnancy. Then means when she conceived, 17 weeks means almost 4 months back. She was minor. She was not completed her 18 years. So she was minor. Then also you need to inform the police. Clear? Fine. Follow protocol. What protocols? You need to inform the police in a written format, submit it to the nearest police station and get a receipt from them, because police may say that, Madam, aapne bataya nahi baat nahi. So there is a punishment for non-informing the POXO case, and that is 6 months in prison. 6 महीने की जेल हो सकती है आपको. ठीक है? You will be behind the bar for 6 months. Months, not weeks, months. It is very dangerous. And documentation, what documentation you need? If she has come for the MTP, then all forms, then whose signature on the consent? If she is minor, parent's signature. Correct. And if she is major, her signature only. No need of second a signature by boyfriend or father or mother, anybody. Okay. Question: do we need a consent for labor? Of course, yes. Can a patient give consent who is in active stage of labor and pains? No. And can a relative give consent for the patient? It is yes. Because if she is in agony, she is under pain, or she is under influence, or she is under any disturbed psychological condition, she cannot give consent. Consent needs a sound mind and sound body. Then and then only the consent is valid. Here, she is suffering from labor pains and she is under some medication. So the consent is not valid. So you need to take the consent beforehand, maybe 1 week prior or 15 days prior, that whenever I come for the delivery, this is my consent given to Dr. Ritu Santwani, patient's name, doctor's name, hospital name, and the procedure. It should be written. It should not be blanket consent. Means pura chhap ke ready hai, sign maro niche, nahi chalega. That is blanket consent. It is not acceptable. Okay, fine, clear. Next. So Foxy has given a very beautiful 30 consents. That is called a uniform consent Foxy. It is given free of cost on the website. Anybody can go there, download for normal delivery, or the rather delivery, the page number 95 to 104 of the book. You need to download it, fill your name, hospital's name, patient's name, and use as it is. Okay. So this is part and parcel of that consent. I am not giving you the detail. Emergency section is also covered under that, and the procedures. Okay. So this is the undertaking where I, patient's name, aged, years, resident, blah, 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 and that is the name of the doctor again, and sign of patient, doctor, and 2 witnesses. Because consent is a agreement between patient and doctor. So we need 2 signatures. One patient signature, second doctor signature, and witness 2. One from doctor side, one from patient side. What does this witness means? Witness says that this signature has been done in front of me. That's all. He or she is not related with the diagnosis, treatment, and anything. He may be out of the hospital patient, he may be relative of the other patients or whosoever, but the witness should be available when asked for. Okay. And here I advise you to kindly ask the patient to give the thumb impression along with the signature, because sometimes the patient get hostile and they may deny that the signature belong to me. So they say कि नहीं वो तो हमने नहीं किया था, डॉक्टर साहब ने खुद ही कर लिया. So this is very dangerous situation. So take a left thumb impression of a right-handed person and take a right thumb impression of a left-handed person, because if something goes wrong, we can send this document to the thumb expert and we can prove that this thumb belonged to the same person. So the signature was of same person. So this is for our safety, I am telling. Fine. Then next situation, G4P3L0, okay, type 2, diabetes mellitus, present at 39 weeks with UFD on admission. What next? Explain properly the truth. And what is the take-home message from this? Take-home message means you need to document all the things. What? Did not come for checkup as advice. If you once write this, you are free of charge of negligence. Because आपने negligence किया है, इससे आप बरी हो जाएंगे, because this comes under contributory negligence, because this is negligence from the patient side. You advise the patient, write it down on the paper, but the patient did not come. So this is the contributory negligence on the patient side. Did not get blood sugar done early, then again contributory negligence, document it. Did not take insulin as advised, document it. And did not maintain fetal movement count as advised. 2 दिन की बात में आया, 2 दिन से तो बच्चा हिला ही नहीं है, मुझे लगा सो रहा होगा, इसलिए मैं आई, and it is a IUFD. Okay. Hello, can you mute everybody? I'm getting some noises, please.
Okay, sir. Okay.
Thank you very much. Document patient's non-compliance in the outpatient record. Then second, primary with a severe PH present at 39 weeks. That was severe diabetes. This is the PH present at 39 weeks with IUFD on admission. What next? Same conditions, but you need to mention did not come for checkup as advised, did not get blood pressure checked regularly with any doctor, did not take treatment as advised. This is contributory negligence. You advised, your part is over. Patient is not following your orders, that is contributory negligence, you are free. Okay. Next situation, patient is in PPH and you have not done the blood grouping prior, as patient was your regular one in ENC. आपके पास register हुआ हुआ patient है और आपने उसको blood group किया नहीं है. Is it negligence? Of course, yes. आपके protocol में ये होना चाहिए कि every patient of you, or particularly obstetric patient who is pregnant, must be done with a blood group. We never know what can be done, because blood group needs at least half an hour, and वो PPH की condition में half an hour में उसका blood कम से कम 1 लीटर के आसपास चला जाएगा. So that will change the total scenario. I'm sorry. Okay. So there is a negligence on our part, and that becomes criminal negligence. That is not civil negligence. Can you mute everybody, please?
Please mute everyone, Saiti.
Okay, ma'am. Okay.
Remain everybody muted till sir's talk will finish. Huh? Yeah.
Sure.
Yeah. Somebody is scratching the table, and thank you very much. And the compensation. What is the formula for compensation? Yearly income of the deceased person into the age, total working age to 70 years. So if she dies at 30 years, so you need to give compensation for 40 years into annual income. Annual income may be 10 lakh. 10 lakh into 40 years, it becomes a huge amount in crores. So it is very dangerous. So try to write down the annual income on your indoor paper so that you can prove कि अरे patient ने तो दिया 2 लाख यार. So compensation will be 2 लाख into 40 years. तो 80 लाख तक सीमित रहेगा. नहीं तो वो 10 लाख बोले तो वो तो जाएगा 8 करोड़. ठीक है ना? So ये हमारे इंडोर पेपर में भी होना चाहिए. Documentation is very important. तो उसमें क्या क्या लिखना है, हम लोग आते पेशेंट आ गए, हाँ चलो ठीक है सर इसको ओटी में ले लो, कंसेंट कंसेंट फॉर्म है ना, आने के बाद में कर लेंगे, एंड इफ समथिंग गोज रॉन्ग देयर इज नोबडी टू sign the consent. So have documentation proper first and then go for any procedure. Okay, fine. Next, do we need a consent for CS? Can a patient give consent who is in active stage of labor and pains, and can a relative give consent for the patient? Same questions, but instead of normal delivery, it is now cesarean section. So we need a consent for cesarean section, of course, yes. Okay. Can a patient give consent who is in active stage? No, obviously. And can a relative give consent for the patient? Yes. Section, I don't mention the section name usually, but there is one section which gives the relative permission where the patient is not in condition to give the consent. So for the betterment of patient, her near relative or whosoever who is standing there on behalf of the patient may give the consent, though he or she may not be her relative or anybody, only companion और शेजारी उसका पड़ोसी भी हो सकता है, पड़ोसी भी हो, पड़ोसन भी हो सकती है जो उसको लेके आए, ठीक है ना, तो दे कैन गिव कंसेंट. अगर कोई नहीं है कंसेंट देने वाला, सो फॉर द बेटरमेंट यू कैन प्रोसीड फॉर द आपका जो इंटेंशन मस्ट बी अ गुड, देन एंड समथिंग गोज रॉन्ग, यू नीड टू प्रूव योर आपका एम जो था, इट वाज वेरी ऑनेस्ट एम दैट यू नीड टू प्रूव. आप कोई इंस्टीट्यूशन में है तो हेड ऑफ इंस्टीट्यूशन कैन गिव द कंसेंट ऑन बिहाफ ऑफ द पेशेंट, and if you are not in any institution, your own hospitals, then you can take the company's consent, or you can proceed without consent in life threatening conditions only, not in each and every case. Okay, कोई देने वाला नहीं था तो हमने सोचा कि अभी कर ही लेंगे, ये नहीं चले. ठीक है. Consent for anesthesia. There must be a separate consent for anesthesia. You need to have a separate consent for anesthesia, separate consent for the procedure, and third one, if needed, separate consent for the blood transfusion. अगर 5 ट्रांसफ्यूजन आप दे रहे हो तो 5 बार कंसेंट लेने की जरूरत नहीं है, एक ही बार कंसेंट लीजिए, 5 बार का अलग अलग डिटेल रखिए. यू नीड टू राइट डाउन एवरीथिंग, द बैच नंबर, कोड नंबर, इट इज फ्री फ्रॉम दिस इज स्टार्टेड एट व्हाट टाइम, व्हाट वाज द ड्रॉप रेट, 15 मिनट के बाद में कितना ड्रॉप रेट बढ़ाया, तो उसके बाद में क्या हुआ, प्रोसीजर सॉरी अनइवेंटफुल, नो रिएक्शन सीन, एवरीथिंग you need to write down at least 2 pages for every transfusion, right? Okay. Then emergency, it is again given in Fox's that sign. Okay. How many years do we need to maintain records? This is a very usually asked questions. For the labor record, it is 21 years. And any procedure, it is given 7 years, but now it is a 5 years because NMC has given 5 years. MTP 5 years, of course, and PCPNDT 2 years, Consumer Protection Act 2 years, but they have now amended it, and after maybe 4 or 5 years, they may lodge a complaint against you, and if the judge feels that the complaint is correct and the patient needs the justice, then he or she may accept the case and proceed with the case. So you are in trouble because after 2 or 3 years, you must have destroyed your papers. And there is a procedure for destroying the papers. You need to give an advertisement or a notice in a local paper and one English newspaper who is at national level that such and such period's record is to be destroyed by our hospital. The patient who needs a copy may contact the hospital. Likewise, you need to give the notice, and after maybe say 1 week or 2 weeks, you can destroy. Destroy means what? Don't give it to Raddiwala. Okay. Just cut it down or burn it. That is the only way out to destroy the papers. Don't give it to anybody, Raddi or anything. चने फटाने वाले वो don't give it. वो confidentiality loss हो जाती है. और by chance खुदा न करता कोई एकादा MTP का पेपर उसमें चला गया ना, फिर तो आपको 1 साल की जेल है. Loss of confidentiality in MTP carries a 1 year jail. Okay. Next situation, unregistered patient. Why I have mentioned particularly? Because there is no moral duty of you with the unregistered patient. Okay. We are there for the patients. We are there for 24 hours for emergencies. But the patient is in not in emergency, so we can do that. So that is why I have given it. unregistered patient came in early labor, pre-labor or early labor, not ready for any investigation. हम कुछ नहीं करेंगे, हमारे पास पैसे नहीं है, and ask for admission and delivery. Can we deny? Of course, yes. Denial is a right of the doctor. You can deny any patient except लाइफ थ्रेटनिंग कंडीशंस. उसको ब्लीडिंग हो रहा है, बहुत ज्यादा उसका ब्लड जा रहा है, मे बी एक्सीडेंट का पेशेंट है, अनकॉन्शियस कंडीशन में आपके पास लाया, बोले मेरे पास रखो मत उसको. अरे कुछ नहीं, उसका आपका उसको अंदर ले लो, उसका फर्स्ट एड करो, एम्बुलेंस में डालो और भेज दो, रिकॉर्ड रखो आपके पास. नथिंग डूइंग, आपको कोई कुछ नहीं कर सकता, बिकॉज यू हैव गिवन द इमरजेंसी सिचुएशन कंडीशंस. फर्स्ट एड देना आपका कर्तव्य बनता है. इट इज गिवन इन द रूल्स एंड रेगुलेशंस. इट इज अप्लाइड एवरीवेयर. बहुत दिनों से, अभी नहीं हुआ, बहुत दिनों से है वो. So we have to treat the patient in emergency condition. मैं gynecologist हूँ, मुझे ये wound का नहीं समझता, ऐसा नहीं. We can at least stop by pressing or having a bandage and everything. So active bleeding तो stop कर सकते हैं, और अपना जो bleeding है वो तो हम कर ही सकते हैं. Okay. So but if she is unregistered, then early labor or pre-labor, we can deny the patient. Send with the proper documentation, consent and referral letter, and keep record with you. रेफरल लेटर देना बहुत जरूरी है, क्योंकि किस कंडीशन में आपने पेशेंट को भेजा वो आपको बाद में एक्सप्लेन करने के लिए ये लेटर आपको बहुत काम में आएगा. ओके. नेक्स्ट सिचुएशन, हियर इट बिकम्स अ रजिस्टर्ड, इट इज नॉट अनरजिस्टर्ड. रजिस्टर्ड पेशेंट, सो मोरल ऑब्लिगेशन आ गया आपका. ठीक है. रजिस्टर्ड पेशेंट विथ रूटीन फॉलोअप केम एट फुल टर्म इन लेबर एंड इंसिस्टिंग फॉर नॉर्मल डिलीवरी. नॉर्मल ही करना पड़ेगा डॉक्टर साहब, हम आपको परमिशन नहीं दे सकते. नॉट रेडी फॉर CS इफ नीडेड, एज fetal हार्ट रेट इज फ्लक्चुएटिंग. आपको लगता है कि नहीं, चलो ठीक है बाबा, 130 से 120 पे आ गया, 110 पे आ गया, या तो फिर 170 हो रहा है, बीच बीच में कम ज्यादा है, उसका डिसलेरेशन के साथ में भी जो होना चाहिए नहीं हो रहा है. सो इट इज अ प्रॉब्लमेटिक कंडीशन फॉर डॉक्टर. हम क्या करेंगे? अगर पेशेंट बोलता नहीं, जबरदस्ती अंदर ले, तो तुम कंसर्ट दे मत दे, मैं इसको लेके जाके सीजर कर ही दूंगी, ऐसा नहीं बोल सकते. विदाउट कंसेंट हम ऐसा नहीं कर सकते. सो वी नीड टू हैव अ कंसेंट. अगर वो इतना कुछ करने को तैयार नहीं, तो क्या करेंगे? तो उसमें एक है कि रिकॉर्ड प्रॉपर फाइंडिंग एंड ऑन एडमिशन. क्या क्या फाइंडिंग्स है वो लिखो. ऑन एडमिशन कंडीशन लिखना. एवरीबडी इज एक्सपेक्टेड टू राइट दैट कंडीशन, बिकॉज दैट विल सेव मेनी ऑफ द कॉम्प्लिकेशंस. Because see, one patient came to you and she is pulseless, you write it down. Pulseless patient, BP not recordable, came in shock, admitted. Then you treat it. If she sinks down, she succumbs, then you are not at fault, क्योंकि वो आई तभी सीरियस थी, आपने फिर भी ट्राई किया. So you can prove on depending on your documents. So record proper findings बहुत important है. Okay, पार्टोग्राम कर लो इसका. ये नहीं कर रहे तो पार्टोग्राम के ऊपर we can discuss or we can prove that it was the point of time where I advised cesarean section, but patient denied. That's why the complication occurred. Likewise, we can prove the partogram is very important. Fetal record, CTG record, that again we can prove that our innocence. Then negative consent. What is negative consent? Patient is not ready for anything. नहीं हम कंसेंट नहीं देंगे, हम बाहर भी नहीं जाएंगे. तो उनसे लिख लो कि हम कंसेंट देने को तैयार नहीं है, डॉक्टर साहब हमको बोल रहे हैं, वॉट एवर, इंग्लिश में या हिंदी में जो भी लैंग्वेज उसमें, कि हम सुनने को तैयार नहीं है, हम कंसेंट भी नहीं देंगे, हम बाहर भी नहीं जाएंगे, एंड कुछ भी हुआ है तो वी आर रिस्पॉन्सिबल एंड डॉक्टर इज नॉट रिस्पॉन्सिबल. उसका अंगूठा वो सब कर लो. ये अगर वो भी नहीं देती है, एक ने पूछ लिया कि अगर वो नेगेटिव कंसेंट भी देने को तैयार नहीं, तो अपने पास दूसरे पेशेंट के रिलेटिव रहते हैं, उनसे आप एक अंडरटेकिंग लिख लीजिए कि ये जो ड्रामा हो रहा था पूरा कंसेंट का, देंगे नहीं देंगे, नेगेटिव कंसेंट भी नहीं देंगे, ये टुक प्लेस इन फ्रंट ऑफ मी. ऐसा उसका एक बार लिख के उसका हैंड राइटिंग आप में, सॉरी उसका सिग्नेचर, वंस यू टेक दैट यू आर सेफ. ठीक. नेक्स्ट, पेशेंट नॉट प्रोग्रेसिंग वेल इन लेबर एंड नॉट रेडी फॉर CS एंड नॉट रेडी टू शिफ्ट टू अनदर हॉस्पिटल. ये तो मैंने अभी आपको एक्सप्लेन किया. सो पेशेंट केम विद हैंड प्रोलैप्स इन लेबर, हाथ बाहर है उसका यहाँ से, थोड़ा ब्लूज भी हो रहा है. व्हाट इज नेक्स्ट स्टेप रिगार्डिंग डॉक्यूमेंटेशन? काउंसिल अबाउट कंसिक्वेंसेस एंड डॉक्यूमेंट. उसका हाथ है, उसमें बाद में एंगल भी हो सकता है, सर्कुलेशन आ भी सकता है, सर्कुलेशन नहीं भी आ सकता. ये आपका बोलना कर्तव्य है. थोड़ा फास्ट बताइए, उसमें ऐसा आधे घंटा उसको डिस्कशन करते बैठेंगे तो नहीं चलेगा. ओके. इसके लिए आपका अगर CCTV कैमरा है एंड CCTV कैमरे में ऑडियो रिकॉर्डिंग है, सो दैट विल हेल्प यू, क्योंकि आपने उसका काउंसलिंग किया था, भले आपके पास डॉक्यूमेंटेशन नहीं है, पर ये वीडियो रिकॉर्डिंग है, दैट इज एक्सेप्टेड इन द कोर्ट. आजकल ये जो कंसेंट है आपका, ये वीडियो कंसेंट भी चलता है. ओके. सो इट शुड बी ऑडियो एंड वीडियो रिकॉर्डिंग बोथ एडवाइजेबल. ओके. सिग्नेचर ऑफ विटनेस, कंसेंट ऑफ द प्रोसीजर। अब ऑब्वियसली हैंड प्रोडक्शन तो पेशेंट का तो नहीं चलेगा, रिलेटिव का ले लेना। पीडियाट्रिशियन मस्ट बी प्रेजेंट ड्यूरिंग प्रोसीजर, पीडियाट्रिशियन तो हमेशा रखना ही रखना है, हर सीजर में नहीं, हर डिलीवरी के वक्त भी पीडियाट्रिशियन रखो, तो आपकी एक जिम्मेदारी डिवाइड हो जाती है। एंड इफ अ सेकेंड एक्सपर्ट इज प्रेजेंट इन दैट सिचुएशन, इट एड्स टू योर क्रेडिट कि नहीं चलो भाई वहां और एक सीनियर था या और एक कंसल्टेंट था हुई स्पेशलिस्ट इन दैट फील्ड, तो आपकी ये कम हो जाती है कि निग्लिजेंस प्रूव होने के चांसेस कम हो जाते हैं उसमें, तो यू आर सेफ, फाइन। उसमें थोड़े पैसे जाएंगे, पेशेंट से ले लो, डॉक्टर को दे देना, ओके। बट एक साथ में कोई ज्यादा करने, बहुत सारे लोग देखा मैंने 3 o'clock 9 o'clock आधा ज़ाइलोकेन का इंजेक्शन फिर डायल्यूट करके दे देंगे, उसी में क्यूरेट करते बैठेंगे, ऊपर पल्स को देखने वाला कोई नहीं, सिस्टर को बोलेंगे तेरा हाथ पे पल्स पे हाथ रख, दैट इज रॉन्ग। कॉल एन एनेस्थेसियोलॉजिस्ट, गिव द जॉब टू द एनेस्थेसियोलॉजिस्ट, वो ऊपर का देख लेगा और ठंडे दिमाग से नीचे की प्रोसीजर करो, थोड़े पैसे कम मिलेंगे चलेगा, अपनी मानसिक सुख शांति के लिए इतने पैसे चलते हैं, ठीक है ना, ओके। टेक प्रॉपर कंसल्टेशन ऑफ अदर फ्रैटर्निटीज में ऑर्थोपेडिक सर्जन वगैरह कुछ लगा आपको तो लेना पड़ेगा, ठीक है। सेम कंडीशन है कॉर्ड प्रोलैप्स है, इसका तो आपको बोलना पड़ेगा कॉर्ड प्रोलैप्स, वो भी पॉलीहाइड्रमनियाज में वगैरह ये होने के चांसेस ज्यादा है उसमें, तो उनको बताना पड़ेगा दीज आर द कॉन्सिक्वेंसेस 1 2 3 4 5 6 7 8, वो भी जो भी है। एंड ये हो सकता है उसका पल्स लिस्ट भी हो सकता है, उसका ये भी हो सकता है, तो इमीडिएटली एज अर्ली एज पॉसिबल आपको ये ऊपर से निकालना पड़ेगा। प्रीवियस एलएससीएस, अब इसमें क्या करेंगे पेशेंट को, गिव ऑप्शन, उनको बोलना है कि देखो देयर आर 2 ऑप्शंस, प्रीवियस एलएससीएस है तो हम सीजर करेंगे, क्योंकि प्रीवियस एलएससीएस अगर सीपीडी का है तो ऑप्शन ही नहीं उसमें, यहाँ तो दूसरी बार भी करना है। पहला प्लासेंटा प्रीवियर के लिए किया था, तो अभी प्लासेंटा प्रीवियर नहीं है, सो वी कैन वेट। पहला अगर उसका क्लासिकल हुआ है तो वी कैन नॉट वेट, उसका लोअर सेगमेंट का ट्रांसवर्स सेक्शन से हुआ है एंड फिटल डिस्ट्रेस के लिए हुआ था, सो वी कैन वेट। सो दीज आर द कंडीशंस डिपेंडिंग ऑन दैट, बट यू नीड टू एक्सप्लेन ईच एंड एवरी कंडीशन टू द पेशेंट, है ना। तो इसलिए गिव ऑप्शंस, उसमें टोलैक भी है, ट्रायल ऑफ लेबर आफ्टर सीजर, तो वो हो सकता है, उसमें डेहिशंस हो सकता है, इसमें रप्चर हो सकता है, ये आप एक्सप्लेन करो, उसको डॉक्यूमेंट करो। सिर्फ एक्सप्लेन करना जरूरी नहीं, डॉक्यूमेंट करना भी उससे ज्यादा जरूरी, ओके। सो इफ यू डू नॉट डॉक्यूमेंट इट, इट इज कंसिडर्ड दैट यू हैव नॉट एक्सप्लेन्ड इट टू द पेशेंट एंड यू आर एट फॉल्ट, यू आर नेग्लिजेंट, ओके। काउंसिल ऑल पॉजिटिव एंड नेगेटिव पॉइंट्स ऑफ द मोड्स ऑफ द डिलीवरी, एकदम से अन्य टेबल पे आप मर भी सकते हैं, ऐसा बोले तो सब पेशेंट भाग जाए, इतना रिमोट पॉसिबिलिटी बताने की जरूरत नहीं, नियर बाय पॉसिबिलिटी जो है वो आप उनको बताइए आराम से, ठीक है। पर्टिकुलरली स्कार डेहिशंस, रप्चर, नियोनेटल मॉर्बिडिटी एंड मॉर्टेलिटी, ये सब उनको बताना है कि प्रॉपर नोट्स एट शॉर्ट इंटरवल्स, ये 15-15 20-20 मिनट में आपका पेशेंट का हार्ट बीट का और वो सब का रख दीजिए रिकॉर्ड। सेकंड ओपिनियन इज नीडेड, अगर सेकंड ओपिनियन आता है तो दैट इज वेल एंड गुड। जैकब में तो केस जो है वो अपना डॉक्टर के स्टैंडर्ड के बारे में एवरीबॉडी नोज अबाउट दैट, आई एम नॉट गोइंग टू वेस्ट टाइम इन दैट जैकब में तो। So keep proper keep paper ready, duly completed, आपको कंप्लीट करना है। एक्सप्लेन द रिलेटिव इन अ साइंटिफिक वे, पूरा उनको बता दीजिए कंप्यूटर और चार्ट्स के हिसाब से, दैट विल बी इजी फॉर यू। आउट ऑफ कोर्ट सेटलमेंट कैन बी एन ऑप्शन, पर इसको डोंट गो थ्रू अ मीडिएटर, इट मस्ट बी थ्रू अ लोक अदालत। व्हाट इज लोक अदालत? बिफोर हैविंग एनी केस, बोथ द पार्टीज, डॉक्टर एंड द पेशेंट, मे गो टू लोक अदालत। वहां पे पेशेंट उसकी साइड बोलेगा, डॉक्टर उसकी साइड बोलेगा, पेशेंट बोलेगा मुझे 10 लाख चाहिए इनसे, डॉक्टर बोलेगा मेरा कोई निगलेंस है ही नहीं, दैट अगर ऐसा हुआ तो फिर वहां लोक अदालत में केस नहीं होता। अगर डॉक्टर ने बोला चलो ठीक है, मैं थोड़ा मान लेता हूं कि थोड़ी सी मेरे से गलती हो गई है एंड आई एम रेडी टू गिव द कॉम्पेंसेशन, फिर कोर्ट डिसाइड करेगा कितना कॉम्पेंसेशन है, वो कैलकुलेशन के हिसाब से, एंड कम से कम कैलकुलेशन वो बराबर करके दे देंगे, वो बोलेंगे इतना इतना सर्टेन अमाउंट है, एक्स अमाउंट, दैट एक्स अमाउंट इज टू बी सबमिटेड टू द कोर्ट बाय डॉक्टर and the court will give official to the patient and here they give a decree। वहां एक फर्स्ट क्लास जुडिशियल मैजिस्ट्रेट जो रहता है रिटायर्ड, उनकी एक कोर्ट की ऑर्डर आएगी बाकायदा, उसमें पूरा ये मेंशन किया जाएगा कि डॉक्टर अजय मानी हैज पेड सच एंड सच कॉम्पेंसेशन टू सच एंड सच पेशेंट। उसके बाद में दुनिया की कोई भी कोर्ट में वो पेशेंट डॉक्टर के अगेंस्ट केस नहीं कर सकते, ये सिर्फ लोक अदालत में हो। आप आउट ऑफ कोर्ट सेटलमेंट करेंगे, कोई मेडिएटर के थ्रू जाएंगे, वो पैसे लेके निकल जाएगा, 4 महीने के बाद दूसरा रिलेटिव आएगा या वही पेशेंट आएगा, मैं अभी केस कर रहा हूँ, क्या करेंगे आप? क्योंकि आपने जो पैसे दिए थे दैट वाज अनऑफिशियल, उसका कोई रिकॉर्ड नहीं, आप रिकॉर्ड रख भी नहीं सकते, है ना। अच्छा, आप चेक से देंगे तो क्या बोलेंगे पेशेंट, नहीं वो तो हमने दिए थे एडवांस, उन्होंने वापस दे दिया, आप क्या कर सकते? सो लोक अदालत इज द ऑप्शन फॉर आउट ऑफ कोर्ट सेटलमेंट. फाइन. देन कोर्ट केस, लॉयर चार्जेस बहुत हो गए हैं अभी आजकल. नो विन नो फीस बेसिस भी आ गया है. सो व्हाट एडवोकेट डू, वो बोलते हैं आप जीत गए तो ये पैसे दो, नहीं जीते तो पैसे मत. सो ऐसा है. तो रिजल्ट ऑफ निग्लिजेंस सेक्शन 304A इज टू बी अप्लाइड. सेक्शन 304 डॉक्टर को कभी भी नहीं लगता. ये राजस्थान की केस में भी प्रूव हुआ है, बहुत सारे केसेस में प्रूव हुआ है. एक पुलिस ने लगाया था तो उसको कोर्ट ने सस्पेंड भी कर दिया है. देयर आर so many incidences. 304A, he is not a culpable homicide. 304A is a death by negligence. इसमें ज्यादा से ज्यादा 2 साल की सजा हो सकती है. इट इज अ बेलेबल ऑफेंस, इट इज नॉट नॉन बेलेबल. डिफेंस ऑफ अ डॉक्टर क्या क्या हो सकता है इसमें? फिर कॉन्ट्रीब्यूटरी निग्लिजेंस मैंने आपको बता दिया है. ड्यूटी डिस्चार्ज अकॉर्डिंग टू प्रीवेलिंग स्टैंडर्ड. व्हाट इज द प्रीवेलिंग स्टैंडर्ड? आपके हॉस्पिटल के आसपास या उस गांव में जो भी गवर्नमेंट मेडिकल कॉलेज होगा, उसमें जो स्टैंडर्ड प्रोसीजर फॉलो करते हैं, वो अगर आपने स्टैंडर्ड प्रोसीजर फॉलो की है, या आईसीओजी, फॉक्सी, एसीओजी, रॉयल कॉलेज, आरसीओजी, ये जो गाइडलाइंस दिए हुए हैं ना WHO, ये गाइडलाइंस में से कोई भी गाइडलाइन आपने फॉलो की है तो दैट इज अ प्रिवेलिंग स्टैंडर्ड. उसके हिसाब से अगर आपने ट्रीटमेंट दी है एंड फिर भी पेशेंट आपका सकम हो जाता है या डेथ हो जाती है उसकी, सो यू आर नॉट एट फॉल्ट, आपका निग्लिजेंस नहीं है. ओके, बट ये प्रूव होना जरूरी है ऑन पेपर दैट यू हैव गिवन इन अ प्रॉपर मैनर. एरर ऑफ जजमेंट. Error of judgment, what do you mean by error of judgment? Misdiagnosis is different and error of judgment. So there are few conditions which are similar, but one may get confused. अभी ये हो सकता है कि ये हो सकता है यार, थोड़ा सा ऐसा error of judgment उसमें तो that is error of judgment, ये कंसिडर करता है कोर्ट. पर अगर misdiagnosis है, आपको पेशेंट इनकम्प्लीट एबॉर्शन में आई, आपने डायग्नोस किया और देखा ही नहीं उसको, ब्लीडिंग हो रहा नहीं, थोड़ा बहुत होता है, पैड भी देखा नहीं आपने, वो आपका मिसडायग्नोसिस हुआ, डायग्नोसिस हुआ ही नहीं आपका. So that is not accepted in the court. Okay. What is the precautions against negligence? Obtain written informed consent, develop good rapport with the patient and relatives, keep full, accurate, legible medical record. It is very important sentence. And never guarantee cure 100%. अरे ये तो मैं कर दूंगा, मैंने बहुत सारे ऑपरेशन किए, 100% क्योर हो जाएगी, ठीक हो जाएगी, अब चिंता मत करो, यूं गया ओटी में यूं आया. नो, आपने बोलना है कि ये 1 2 3 4 पॉजिटिव पॉइंट, ये 1 2 3 4 नेगेटिव पॉइंट्स है. नाउ यू डिसाइड, लेट देम डिसाइड. उनकी भी बातें सुन लो, डॉक्टर साहब हमने ये सुना था, ऐसा है, वो सुना था, अरे वैसा कुछ नहीं, वो बोलो मत, मेरे को टाइम नहीं है, चलो चलो बहुत सारे पेशेंट है, जल्दी ले लो. डोंट डू दैट. गिव देम प्रॉपर टाइम, गिव देम प्रॉपर टाइम टू थिंक. उनकी भी 4 बातें सुन लो, आपकी भी 4 बातें, इसका रिकॉर्ड रखो, डॉक्यूमेंटेशन पे रखो, ये ऑडियो रिकॉर्ड. दिस इज गारंटी गिवन बाय सम क्वैक. डोंट डू दैट. सो एंटिसिपेट ऑल द प्रॉब्लम्स, bad consequences, and keep documentation about followed all protocols, partogram, nothing was missed, done everything according to the prevailing standards, and all consents with proper procedure and all records. What is the take home message? Follow all protocol, document, train staff. Drills बहुत जरूरी है अपने पास, क्योंकि एकलमशिया के पेशेंट आते हैं, पीपीएच के पेशेंट आते हैं, इनके लिए मान्यता में दिया हुआ है, बाकी सारी चीजों में दिया हुआ है. आप ड्रिल्स करो, पेशेंट को बोलना अब ये सिचुएशन आई है सिस्टर, आप क्या करेंगे, क्योंकि हर बार डॉक्टर अकेला कुछ नहीं कर सकता. कॉल फॉर हेल्प, दूसरा डॉक्टर बुलाओ, या तो नर्सिंग स्टाफ है, तो फिर नर्सिंग स्टाफ इधर से उधर भागेंगे सिर्फ, नहीं नहीं मैडम वो कहाँ है, रखा नहीं, अभी मैं तो भूल गई, तू तो टेंशन ही आ गया. सो हैव अ ट्रेनिंग एंड ड्रिल्स. अगर आप ड्रिल्स हमेशा हमेशा करते हो तो उनकी तो आदत हो जाएगी. चलो, और सही अगर पेशेंट आ जाता है तो उस वक्त बराबर उनको इंजेक्शन मिलेंगे, प्रॉपर दे देंगे, रिकॉर्ड भी बराबर मेंटेन करेंगे, क्योंकि एवरीथिंग इज नॉट डन बाय डॉक्टर. एक मेरा इंसिडेंस बताता हूँ इसमें. मेरे हॉस्पिटल में जहां आई वाज डायरेक्टर एडमिन, तो उसमें एक पीडियाट्रिक सर्जरी का केस था. वो मल्टी स्पेशलिटी हॉस्पिटल था, वो 200 बेडेड उसमें था, मतलब है अभी भी. आई एम नॉट देयर, बट नाउ आई गॉट रिटायर्ड फ्रॉम दैट हॉस्पिटल. तो वहां पे वो डॉक्टर ने सब केस किया, 15-20 मिनट में ओटी से बाहर निकाला, तो एनेस्थेटिस्ट निकल गया दूसरे केस के लिए, रिबाउंड बैठा, बच्चों को वेंटी पे डाले, पर बच्चों से कम 6 घंटे बाद में.
Sorry to interrupt you.
हो गया?
Some doctors have joined from Cairo and Saudi Arabia. You can see they are putting the comments. Please use English.
Okay.
See, doctors are putting the comments.
Fine,
Sorry to interrupt you. Yeah.
Fine.
Yeah.
No problem. I'm so sorry. Okay. Then the patient succumbed. Okay. And the police came, they took the paper. The surgeon could not complete the paper as police took it. Okay. But when we fought in court, we can prove to the judge sahab that the charts maintained by the nursing staff that indicates the injections were given. all resuscitation measures were given, though it was not written by doctors. Okay, so there are two parallel records. One is by doctor and second is by nursing staff. Whatever they give, they maintain a chart. One sister writes down, one sister gives the injection, one sister writes down, or the second sister writes down. There are 2, 3 sisters, they can help there. So the chart saved our hospital. So this is not a simple thing. Only depending upon that chart, the first class judicial magistrate and the district magistrate, they accepted, okay, the treatment has been given properly and there is no negligence. So our hospital is freed from that charges of negligence. So this is a very simple thing to see. Nursing staff has done their duty and they have given the chart. But though the doctors' notes were not there, so what routinely it would have been considered that nothing is done. No resuscitation is done by a doctor, as there is no note. If this situation occurs at your hospital, police don't give you time. At least they should give 36 to 72 hours to complete your paper, and then they ask for the paper. If they do not give you time and they said, no, I wanted this paper just now, I will not give you the time to complete the paper, just write down there one sentence, this paper is incomplete. The police has not given me time to complete the paper as I was busy in resuscitating the patient. Hence, write down one scratch, then sign their time and date. Every time have a habit to write down the time and date beneath your signature. That is very important. So you can prove that this signature has been done at this time and at this date. So have a good habit. Fine. This is just a slide put which is not concerned with this, but PCPNDT and MTP. What is the difference? One consultant may have many centers for MTP, as well as can go to many centers for MTP, but not possible for PCPNDT. For PCPNDT, only 2 centers are allowed as on today. Case is pending in the High Court. But as on today, there are only 2 centers are allowed in one district. You can go to another district for another 2 centers. But for each center, you need to write down your timing. 10 to 1 at one center, then 2 to 5 at second center, then another district, night 7 to 11, maybe whatever, maybe. But only 2 centers for PCPNDT, but MTP, it is not like that. You can go to any recognized place. For proper patients, you can perform MTP. I can go to Ritu's clinic and perform MTP. Maybe Dr. Ritu may come to Aurangabad and perform MTP. If you change the state, I may go to Madhya Pradesh or Uttar Pradesh for some conference, and there I need to perform one MTP. In that moment, I need to inform the State Medical Council that I'm here for the surgical workshop or whatever, and I'm going to perform this. Just inform. Not taking permission, only inform, and then you can perform all over India. Fine. What is next difference? One may perform MTP at any recognized approved center in India, but PCPNDT, it is not possible. You can perform the sonography where your name is written on that center. Then and then only you can perform. Okay. Then no regular inspection mentioned in law for MTP centers. For PCPNDT, it is mentioned. Every 3 monthly, the approved authority or their representative must come to the center and have an inspection. But for MTP, it is not given. But nowadays, they see the MTP papers also, because the approved authority are same for both. Previously, it was not like that. Previously, the authorities were different for MTP and PCPNDT were different. No renewal for MTP, and for PCPNDT, every 5 years, you need to renew the registration. And the renewal fees is 50% of the registration. If you have got only sonography center, it is 25,000, renewal 12,500. If it is IVF center, sonography plus IVF center, it is a 35,000 plus renewal is 17,500. And whatever the ART law says, that is additional fees. But for PCPNDT, I am telling you the fees. Sorry. Place is approved and not restriction on persons. I told you that. No, anybody who is recognized by a degree may come to my official center and on proper recognized patient or that patients which suits the conditions, 5 before 20 weeks, that 7, 24 weeks, and maybe board after 24 weeks. Okay. Non-bailable, cognizable, and non-compoundable both are like that only. And rigorous imprisonment 2 to 7 years CPC, penalty, MTP. And again, I'm here. If you need anything, you can call me at any moment. This is my mail ID. The second one is not in active stage. You can mail on this, or you can call me on this number. And this will be completely free of cost. I don't charge anything for doctors. And I have never advised any patient against doctors. I will not do that, because I am here to help my colleagues, and you should help your colleagues. Okay. This is woman empowerment. In foreign countries, she carries gun for her baby and herself. But in India, she carries gun for the nation and state for her unit. And she is standing there as a doctor for the nation in China Glacier. So salute to Dr. Captain Deepashika Chetri. And these are the real heroes who have given 200,000 or 200 lakh of vaccinations, going to such place and giving the vaccine. See, these are the workers. So they are real heroes. She is sitting with the baby, the vaccine carrier, her husband in a Kachaka run, that is on, and doing her duty. Salute to them. And thank you very much. Please help your colleague in any bad situation, because the time may come on anybody. And if these birds can stay together, why can't we? So stay together, help everybody. Don't give bad mouth publicity to anybody. Are you have gone to that doctor? God save you. Don't say like that. Okay. And best luck. Thank you. Thank you very much.
Thank you. Thank you so much, sir, for such a brilliant presentation. And sorry, friends, some friends have joined. Dr. Nagla, you can ask your queries now in English. Sir is ready to answer. And Dr. Mona has also joined from Saudi, and Dr. Nagla is also. So they are constantly
Okay,
sending me the messages. So friends,
I'm
because
so
there
sorry.
are
I'm so sorry.
no problem.
I thought
So,
only, yeah.
yeah, because friends, because these are the some common queries we are getting in our day-to-day practice. So we feel comfortable asking some things in Hindi. So these are the sir are discussing the rules and regulations what we are following in India. So regarding if you're having any some queries, you are free to ask here.
Yes.
Sir, thank you so much, sir. You motivated us to do a lot of good work. Sir, as you have shown the presentation for this MTP also, sir, so there are a few queries. If you permit me, I will start. Yeah.
Yeah, please,
Sir,
please.
yeah. Sir, first and foremost query, sir, today only I got one patient in my OPD. She's unmarried lady, 34 years. So she has come with her sonography report. She is 24 weeks pregnant. Huh?
Okay.
So she asked me, ma'am, in which hospital you are going to do my delivery, and which hospital? And my husband, I don't know my husband. She's unmarried, so she's not aware. So what are the rules and regulations for such patients for the delivery in our India?
Okay. See, basically, if she is married or unmarried, and
she's 34
okay,
unmarried.
she is major, it makes no difference for us. First thing.
Okay.
Second thing, the pregnancy is not of rape, so it can be terminated after 24 hours also, 24 weeks also. Because for rape, the upper limit is 24 weeks.
Yeah.
If she has crossed 24 weeks, then you need to send her to the medical board, then get a permission from the medical board within 3 days, and within 5 days of that permission, you can terminate the pregnancy in your hospital. There is no need to send her to the government medical college or government hospitals. You can terminate it with the opinion of 2 doctors of category D, means the degree diploma holders of MCI recognized in your hospital. That is the answer. And one more thing, as she is unmarried, you get a consent in form C, that is routine. But as she is unmarried, get another consent on a blank paper or on your letterhead that this pregnancy took place with the consensual sexual activity. And I don't have any objection, or in future, I don't have any grudge against the doctor or my male partner. That will be additional consent as she is unmarried. That is a due precaution, extra precaution for all of us.
Thank you, sir. Sir, my question, sir, she want to get delivered at the full term. So, is it any rules and
Oh, okay,
regulation?
okay.
She don't want to
No,
abort.
no,
She
no.
want to,
You want to continue the pregnancy?
she
Then
want
well
to
and good.
continue
No
the pregnancy.
problem. No problem. No problem. You can do it in the routine ways. No problem.
And then at the time of the delivery for father's name, what should we write? Because she
You
needs,
ask. Yeah,
she
no. You ask her.
she was asking me how we can proceed for the birth certificate.
Yeah,
I
yeah.
told her
Now,
that
now
for
we.
that to we have. Yeah.
Now in India, we can have mother's name at the place
Huh.
of father's name. That rule has been passed.
Okay. Okay.
Yeah.
Okay. Okay. Thank you, sir. Sir, Dr. Nagla is also writing. Thank you for your presentation.
Thank you, sir. Thank you very much.
Sir, my another question, sir, what are the rules and regulation? Because these questions I'm asking you what we are getting in our daily OPD, the scenarios.
Yeah.
Lady has come that she is pregnant now with by the husband's friend, and husband is out of country now.
Okay.
How to proceed in that cases? Both
Same
are,
situation.
yeah.
No, same situation. Just we need for MTP or
For MTP. For MTP.
okay. Okay. For MTP, we need consent of woman only. There is no need of consent of husband or boyfriend or anybody. We need only consent of that woman if she is a major.
Okay. Okay.
Okay.
So means you have solved my so many queries. If the patient is a divorced lady, in that case also her consent is sufficient if she is major.
Yes.
And so many couples are coming, these who are at live-in relationship, because I am getting these
Correct.
kind of patients. So live-in
Correct.
relationship, if they are coming of the major, so can we go ahead only by the consent of the female?
Correct.
Okay.
Correct.
Okay. Okay. Thank you. Thank you so much, sir. Sir, Dr. Usha Goenka, madam has joined, president of Kanpur Society. Yeah, madam is
Yeah,
also
namaste,
writing
madam.
wonderful presentation. Yeah, thank you, madam, for joining. Sir, there is one more question.
Yeah, please.
If a guy is with NRI girl and the girl is underage, is not major. So what are the rules and regulations for MTP? The guy is of the age of 24 and the girl is of 17 years, but the girl is NRI.
See, basically, okay, no problem. Basically, see, the male partner's age doesn't make any difference. Okay, the
Okay.
age is considered of female partner. If she is a minor, then you need to have consent of her partner. Parent. Okay, not partner, parents. If she is a minor.
Okay.
Okay,
And
parent or a guardian.
And if she is married, if she is major, then?
If she is major, then only her consent.
Okay. Okay. Okay.
And if she is NRI also, in India, the Indian rules are applicable to everyone. Okay. Including Jammu and Kashmir nowadays. Previously, it was not there, but now it is included. Yeah.
Okay. 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 Thank you, sir. So Dr. Kiran is also writing the excellent presentation. Yeah.
Thank you very much.
Yeah. Sir, one more question. Sir, sometimes this happens that once the patient come in our OPD that she want to go for a MTP, and we have seen the patient is of major, patient is 24 years, and we are going for the procedure ahead. And after 2-3 days, because this is I'm sharing a scenario one doctor has shared with me. After 4-5 days, the another party has come to the doctor's OPD and saying that patient has a underworld connections. So why you had done that? But how come the doctor who is sitting in the OPD who had an idea that the patient is from underworld or what? So in that case, the doctor become very panicked. So how to cope up with these things?
See, basically, we are not there to judge the condition of the patient, age of the patient, marital status of the patient, or the social status of the patient. Okay, we are there to treat them.
Yeah.
So ask a Aadhaar card or a valid birth proof for every patient. That is one solution.
Yeah.
So depending on that, you will come to know that exact age of the patient. If she is major, she is giving consent, you are not in trouble. If she is a minor, you need a parents or the guardian signature. That is true. Okay. So we don't basically judge the patient. Uska kahin bhi, she may be.
Yeah. That's correct. That's correct. Sir, now one very important
Acha,
question.
isme
Sir,
one
Yes, sir.
additional
Yes, sir.
thing we do basically. There is one another situation. Okay, you do a termination. After 2 years, the husband gives a letter to the police that by force the Mica people, the in-laws, the mother of the girl, she forced and in conspiracy with the doctor, they have terminated the pregnancy, and doctor is accused number 3. So in that situation, what you can do? So for that, we preferably take husband's signature as a witness. Preferably, if the husband is present there, we take. It is not given in law. It is not needed also. But with abundant precaution for safety of ourselves or doctors, we take the husband's signature as a witness and ask him to write down his name in his handwriting and take thumb impression, so that afterward he comes and by force you made it. So we can say that, see, beta, here is your signature, and you cannot now say that it was done by force. Okay, so we can prove the situations like this.
Thank you so much, sir. Sir, you have cleared one more my doubts, because sir, 2 days back only on the Saturday, I got one patient in my OPD. She is 6 weeks pregnant, and she told me her husband is expired only few days back. So she want to go for a MTP, but her in-laws are not allowing. So in that case, and she is 26. In that,
yeah, we can do.
Go ahead, no? Because okay, thank you so much.
Because in this situation, husband dies or she is divorcee, it is allowed up to 24 weeks also.
Yeah. Thank you so much, sir. So now one very important question, though it is not related to this, sir. Most of the times when we are doing this live shows, so many drugs we are discussing. So sometimes some junior or some our colleague ask for the brand name of the drug. So is it any a problem if we can take the brand name of the drug? Usually we are not taking, we are telling about the content. Because 3 days back only some doctors have put me a message that one doctor has got a very much trouble for that he has taken a brand name of the medicine. So I thought today we are having a sir, so we can discuss with you on the.
See, basically NMC, National Medical Council has given guidelines.
Okay.
You should not give the trade name, or you should not use the trade names. But some of the other cases we need to write something, because see, the situation is like that. The all medical walas, the medical owner, they are not proper medical owner. They keep somebody who is a local guy, who is not a pharmacist. Okay, unless and until this system is improved, we cannot say only I have written down isopropyl hydrochloride. That boy may come, sir, what you have written, I don't know. So, oh, it is there. So we can write trade name, no problem. But we cannot promote a trade name.
Okay. So thank you so much, sir. Today we have a very excellent presentation by both of our speakers. I'm grateful to both of you, Ajay Manes sir and Kanchan Sharma madam.
Thank you.
If there are any questions you are able to see, Nishant, we can take it.
No. I have seen Oswal sir's notes, consent. He has given very nice way. Thank you, sir. Thank you for that.
So with this, we will wind off.
Thank you.
No questions, na? Yeah.
Thank you, Nishant bhai, and thank you, Ritu ji, for that.
Most
thank
welcome,
you, Kiran sir.
It's my pleasure that you have joined. Thank you.
Usha madam, thank you very much for remaining there till end.
Namaste, Usha ma'am. How are you?
Good. Thank you so much. I really enjoyed the talk. Thank you so much.
Thank you, madam. Thank you very much.
You are really
helpful.
Sir.
And one question. One question is regularly asked. I forgot to mention it. If police comes and demand for the paper, shall we give it or not? So, for MTP, for PCP, NDT, and all the case, it is a cognizable offense. No, the police can inquire. They may ask you the paper, Xerox copy. Don't give them original copy. Xerox copy, and they must ask you in written format. One application should come from their side. Such and such patient's paper is needed for the investigation of such and such case. and that must be given by the PSI or PI level, not constable level. Okay, then you can give a hard copy, photocopy, giving number 1, 2, 3, 4, 5, 6, 7, 8, and take a receipt from them that these are the papers of such and such case. So as per your request, we have given this to you, and take a receipt from. That is a part and parcel of legal proceeding. So you must give the paper to the police.
Okay.
Okay.
Okay, sir. Thank you. Thank you.
Thank
Thank
you.
you so
Thank
much.
you
for
very
your
much.
life.
Okay.
So friends, with this, we are winding up for today. A day after tomorrow on Saturday, again, we are connecting at 9 p.m. I'm going to discuss regarding about the male infertility from taboo to treatment, a very interesting talk, and another talk on the LPD. So those who all are interested, all are welcome to join and make our discussion interactive as usual. And on the 5th of April, I am having the Dr. Sunita Tandulwarkar madam with me, again with the same discussions. So why everybody should know hysteroscopy. So do stay tuned. I will keep on posting. Again on the next week, we are having Dr. Geetendra Sharma with us. More medical legal implications or queries what you are having, we can connect and discuss. So with this, we are winding up for today. Yeah, bye-bye. Good night.
Thank you.
Thank you, sir. Thank you.